So can we go ahead with next presentation?
Yes, sir.
Yeah, thank you, Dr. K. Now, coming to the next important presentation of this session is clinical management of sexual dysfunctions in males and females. Very important clinical topic in day-to-day practice. And to guide us on this topic, we have Dr. Prashant Baspure, who is a psychiatrist, is expert in sexual medicine. He has been workshops on sexual medicine, avid researcher. I know him as a psychiatrist, also as a sexual medicine expert, and his role as a medical. So I present Dr. Prashant Baspure. Over to you, Dr. Prashant.
Hi, good evening, everyone. First of all, I would like to thank Synapse team for giving me this opportunity to come on this platform and speak on this topic. So the topic given to me is that clinical approach to sexual problems in males and females. So I understand it is a vast topic, there's a lot to tell and a lot to discuss, but not sure how much I can justify this. So without wasting time, I will go through the basically the next slide. You can see here the linear model described by Master and Johnson. Basically, we all know that Master and Johnson, they are the pioneers in sexual medicine, diagnosing sexual disorders and the treatment for the same. So they studied a number of men and women, almost 10 years, and they found that there are some sexual physiological changes in men and women, and they came out with the concept of sexual response cycle. And they have explained here. You can see this linear model where they have describing like excitement phase. There are different phases: excitement phase, then plateau, then orgasm, and resolution. So next slide, if I talk about the Kaplan's model of sexual response. So Kaplan, we all know that she's like a pioneer in sex therapy. So she has added a few more dimensions into sexual response cycle in this triphasic manner. Triphasic means there are three phases she has explained, like desire, excitement, and the orgasm. So why I have directly started with this presentation directly with the sexual response cycle, because when we understand the basic these phases like desire, the excitement, and the orgasm, then it is easy for us to classify the different sexual dysfunction. For example, if we see the desire the phase, if someone has issue in the desire phase, then it is desire disorder. Someone has issue in the excitement phase, that is excitement disorder, and that's arousal disorder. And someone has issue in the orgasm, so it is classified as orgasmal disorder. So here we can see I have entered these sexual dysfunctions accordingly in different phases. If we see, first of all, we'll discuss about the sexual dysfunction in men. So I have divided in three phases. Desire phase. So what sexual dysfunctions are covered under desire phase? So first one is hypoactive sexual desire disorder. So as name indicates, so there is a less sex desire. So whether there is a persistent lack of sexual desire, lack of fantasies, and lack of sexual thoughts, that is called as hypoactive sexual disorders. And extreme form of lifelong hypoactive desire that leads to asexuality. So almost 1% men, they come under asexuality. So next one is hyperactive sexual desire disorder. So actual name itself indicates that the person would be having the repetitive obsessive sexual thoughts, which he get distressed, and it impacts his day-to-day activity and his functionality. So next one is sexual aversion disorder, where there is a persistent and recurrent aversion or avoidance of sexual contacts with the partners. That's what is called as sexual aversion disorder. So that we cover the desire phase. So three sexual dysfunction comes in the desire phase. Next one is arousal phase in men sexual dysfunction. So erectile dysfunction, it represents the arousal disorder. So erectile dysfunction is one of the common sexual dysfunction. We all know that. And basically, if you see, every man has to go through this phase at least once in his life. So basically, it is that common. And the next coming to orgasmic phase. So all ejaculatory disorders are covered under orgasm phase. So because that is a peak point, and we'll start with the premature ejaculation. So premature ejaculation, I feel it is the most common sexual dysfunction in men. So premature ejaculation means someone is ejaculating before the penetration in the vagina or within 1 minute of penetration and against his will, which is distressing for him as well as his partner. So that is called as premature ejaculation. So almost 30 to 40% men are suffering from premature ejaculation. And if we talk about the classification, so premature ejaculation is classified into the lifelong premature ejaculation and acquired premature ejaculation. So what has been the lifelong premature ejaculation? It means someone is ejaculating from very first sexual experience, that is called as lifelong premature ejaculation. And what is acquired premature ejaculation? Means someone is performing well for first few years. However, later he started ejaculating quickly. So that's why it is called as acquired premature ejaculation. So next one you can see here, the delayed ejaculation. The delayed ejaculation means the persistent or recurrent delay in the orgasm, that is called as delayed ejaculation. Unejaculation means the person is not able to ejaculate at all anytime in his lifetime into vagina during intercourse. Then retrograde ejaculation, the last ejaculatory disorder, whenever there is a failure of closure of bladder neck, that results in semen being pushed in the bladder. So that is called as retrograde ejaculation. So that was all about the sexual dysfunction in men. Now coming to sexual dysfunction in women, again it is divided in the same three phases. The desire disorder, it is the same as in men, that is hypoactive sexual desire disorder and sexual aversion disorder. So we already understood the definitions of these two disorders. So I'm not going in detail for this. Then coming to arousal phase. So arousal phase in women is a little bit different for the men. In men, it is the arousal disorder is very evident. Whenever there is no erection, it is an arousal disorder. But in women, arousal disorder is not that evident. The lack of lubrication represents the arousal disorder. So the lack of lubrication is the hallmark in female arousal disorder. Coming to orgasm phase in women, that is female orgasmic disorder. So whenever the woman, there is inability to have orgasm even after normal desire and normal arousal. This woman experiences desire phase, arousal phase, but not able to get the peak pleasure and not getting the orgasm. That's why it is called as female orgasmic disorders. The other dysfunctions are covered under pain during sex. The first one is dyspareunia. It means the pain during coital act. The next dysfunction is vaginismus. It is very common in women, and we get on daily basis so many couple that comes and women would be having vaginismus. So what has been the vaginismus? Basically recurrent or persistent involuntary spasm of musculature of outer 1/3 of the vaginal muscles, and that is interfering with the penetration. So that is called as vaginismus. As I was saying that many people they come and woman would be experiencing the vaginismus, and that leads to unconsummated marriage. So we get so many cases, so many couples who are struggling to consummate their marriage like 17 years, 15 years, 10 years, just because of this vaginismus problem. Then the last one, the phobic fear of penetration, where the woman has fear of penetration. She may not experience pain, however, she has fear, and because of this fear, because of this phobia, she will not allow the male partner to penetrate in the vagina. So before going to next part, I would like to discuss here the probable etiologies because uh, since we have less time, I'm not giving the etiology for every disorder separately. It is I am just covering the common as a common probable etiologies here. So this for all sexual dysfunction overall. So if we talk about the common causes, then we'll go for the organic causes first because there are organic causes, psychological causes, and lifestyle causes. So let's talk about the organic causes. So mainly organic causes, if we talk about them, the metabolic diseases are very important. For example, the first one is obesity. So obesity itself, it is independent risk factor for sexual dysfunction. And if we tell the obese person even just to try to reduce the weight, so the weight reduction improves sexual dysfunction by 30% without any medication also. Then the next risk factor is hypertension, and half of the elderly men with erectile dysfunction, they have hypertension. It is that common hypertensive people. Then coming to diabetes mellitus, and we all know that this is one of the leading cause for different sexual dysfunctions. And diabetics having risk of having ED, that is erectile dysfunction, 3 times higher than the non-diabetic people. And diabetic people may need a treatment for lifelong with PDE5 inhibitor. And we have seen that diabetics, maybe they are resistant for this treatment, and they may need the higher dosage of PDE5 inhibitor compared to the normal population. Then coming to next risk factor is the cardiovascular disorders. As we know that the heart is the organ where who pump out the blood and gives blood supply to all the body organs. So any disorder, cardiac disorders obviously leads to different sexual dysfunctions. So now we spoke about the organic causes, the metabolic diseases. Now, what are the psychological causes? So mainly, as a psychiatrist, we diagnose lot many psychiatric disorders like anxiety disorders, general anxiety, even the panic attacks. Even we see the ovulation anxiety. Specifically, ovulation anxiety means the person would be able to perform other days, and their couple is really trying hard to get conceived. But whenever they know that this could be the ovulation period, the man is not able to perform. Man is not able to get erection because there is a huge ovulation anxiety he has. Then next psychiatric disorder is major depressive disorders, and obsessive compulsive disorder also leads to desire disorder and erectile dysfunction in men. Relationship definitely matters. So lots of interpersonal conflicts leads to the desire disorder and the arousal disorder. And nowadays we see that a lot many men, if they found that his partner is having extramarital affair, so that leads to desire disorder and erectile dysfunction. Even own extramarital affair itself causes the less desire having sexual contact with the partner. So any negative thoughts or negative views or negative attitude towards sex, that also leads to lack of desire and arousal disorder. And we have seen in many families, the families are very conservative and there is a strict environment in home. So that also the people may develop into the desire and arousal disorder. I have seen many women who come to the clinic, they would be having the body shaming for even though everything is perfectly all right, but there is a body dysmorphic disorders. They don't like the body. That itself causes the arousal and desire disorder. So many young men, they come in the clinic with masturbation dependency history, and that leads to severe guilt. Severe guilt secondary to masturbation itself causes erectile dysfunction. So these are probable psychological causes for different sexual dysfunction. Now, lifestyle factors, if we talk about, so nowadays after COVID, so the life has changed a lot. So mainly, most of the people, they're working from home. And they're working for 12 to 14 hours a day non-stop, and they're continuously with the system. So obviously, there is huge work pressure that leads to all this sexual dysfunction, the burnout, they get burnout, lack of rest, lack of sleep. This kind of lifestyle definitely affecting them, their sexual life, right? So these were the sexual dysfunctions, and so basically the probable causes in men and women. So next part, so one more cause is that is iatrogenic. So means We prescribe a lot many medications to patients for different disorders. In psychiatry, we prescribe different SSRIs, which can, because of the mechanism of action, that causes sexual dysfunctions. Even antiepileptics has a role in sexual dysfunctions. The alcohol, different substances, very common in young generation nowadays. So that also leads to different sexual dysfunction. So that is iatrogenic cause. So we till now we discuss about the sexual response cycle. We discuss about the different sexual dysfunction classification and the probable reasons, probable risk factors. And now, most another important aspect of the presentation is history taking, which is very, very important. And we all know that when a patient as history taking is really hard. It gives lots of information to diagnose the patient. So whenever patient comes to the clinic, it is very important that usually I recommend my every patient to come as a couple so to get maximum information from the partner also. But many times they come alone, so accordingly we need to take the history. So why history taking is important? Because around 75% of diagnosis comes from the detailed history. 10% diagnosis comes from the clinical examination, and remaining 15 to 20% diagnosis comes from routine investigations or some specialized investigation. That's the reason, if you see the percentage, as I said, 75% comes from the history taking. So it is that important. So what is included in history taking? So general information, basically a patient's age, what is his or her occupation, the marital status, that the patient is single, married or divorced. It gives a lot many information to you. The medical history, personal history, that comes under general information. The problem for profile means problem is in one partner lead to dysfunction in second partner. For example, it is very important to call them as a couple to get the proper history. Just single person cannot give complete picture, right? So for example, why it is important, I will tell you. For example, if the woman is suffering from vaginismus, but that may, if it is persistent, so that may lead to erectile dysfunction in men. So obviously, it is one partner ended up into having sexual dysfunction in another partner. Similarly, the man with persistent premature ejaculation, that lead to loss of sex desire in women. That's the reason it is the proper profile. It is not just one partner. The second partner also can suffer from this sexual dysfunction. Then the sexual profile. If you see, there are different points here during the sexual profile. So orientation is very important. The good history taking only give the orientation, because it's very difficult to make patient comfortable, and usually they don't open their orientation. But unless until you know the orientation, whatever treatment you give, that will not work. So asking orientation with open-ended questions and closed-ended questions, that helps you to get the orientation. Then gender identity, where the man feels that he is a woman but strapped under a man's clothes. On the other hand, woman feels that she is a man but strapped under the woman's clothes. So to get this history is very important, so that accordingly you can decide the treatment plan. The masturbation, the frequency of masturbation, the method of masturbation history is very important, because we see on daily basis that the man masturbating with normal technique that is holding in hand may not end up into having sexual dysfunction. However, the man who is masturbating by rubbing against the bed or rubbing against the bed or surface may end up into having the biliary ejaculation or the unejaculation problem. So the history only will give you the proper way to diagnose the patient. Then premarital history. Nowadays we see that young generation people, they have multiple relationships before their marriage, right? So this history is very important. How many partners he or she was with, and the sexual practices, and how frequently they change these relationships. Because I have seen that they were doing very well before the marriage, but however after marriage they're not able to perform in bed with the partner. So this history will help to guide them properly. Then marital sex, yes, the marital sex, the frequency of sex, how many times it's happening, because nowadays life is so busy. So I have seen a young couple, if I ask them when was the last sex they have, so they said that probably 3 days back, 3 years back, 4 years back. That is the real example. The frequency is also important. Then extramarital sex, as we discussed. Then the fantasies, basically the person having weird fantasies before marriage, and when the person get married, so he may not get the same stimulation in the marital life. So obviously, he'll not be able to perform. So understanding the fantasies, getting this history is very, very important. That is possible only when you get proper history from the patient. Some people, they would be dependent on the some sexual material like porn, watching porn. That history is very important so that you can decide the treatment. And the contraceptive procedures, we know that, for example, the oral contraceptive pills itself notorious that they reduce the sex desire. Then you get a lot many men who come to the clinic and say that, doctor, I'm not able to maintain the erection. I lose my erection. Then I put condom on. So that is a very common example. So that so this history is very important. So next point is history of sexual problem. Means the onset of problem is very important, whether it is acute or it is chronic, because that will differentiate the organic versus psychogenic cause. If it is really acute onset, so that could be psychogenic probably, and if it is chronic, that could be a organic sexual dysfunction. Then whether the sexual dysfunction function is situational or global, as I discussed, that is ovulation anxiety. So if only the person is not able to perform during ovulation, that is situational. Global means for every attempt is having the sexual problems, that is the global sexual dysfunction. This is possible only after getting good history. So that was just some brief idea but why the history taking is important. But little bit the strategy means how we should be equipped taking this history. First of all, whenever patient comes, it is very important to introduce yourself, because many times maybe they will go through the Google and they know the clinic name, and they may not knowing your name. So it's very important to introduce yourself. Then explain the confidentiality. How much ever your clinic is posh, but I have seen that most of the patients, they are really not comfortable when they sit on the chair. They're a little bit paranoid. They don't know where I came and who am I talking with. But when you tell that person, taking into confidence that whatever we discuss, it will be confidential and that will be between you and me only. Please do not worry, just sit comfortably. You can see the facial expression changes immediately. That's the reason explaining confidentiality is really important. Then listen to patient empathetically, though don't be in a hurry, and because don't show sympathy, but showing empathy is really very important. And we should tell the patient that, I understand you are giving me a lot many information, but I may ask you few more questions to get the clear picture. So this idea we should give the patient so that the patient is ready. He knows what is going to happen. Also, you can add one more sentence that few questions may be awkward, but it is important for me, because otherwise tomorrow patient should not blame that the doctor is asking unnecessary questions to me. So if you make aware that there could be some awkward questions, so the patient, I have seen that patients are really comfortable for that, and then they give each and every information to you. Also, whenever they are discussing with you, you should give clear picture what exactly going to happen in the clinic. You tell them, I'm going to take history, I'm going to examine you if it is required, and the investigations if it is required again, and if you are trying to refer that patient to somewhere else, for example, neurologist or endocrinologist, so it has to be given clear idea to the patient. And don't forget to thank patient to keep that happening. I will just try to move fast. So the communication skill also involve. Don't ask closed-ended questions, because we will not get complete picture of the problem. So ask open-ended questions. So that will help you to get the more information. For example, I've seen that. So you see a very happy couple sitting in front of you, and you assume that the relationship is really good. So you can ask that, I hope your relationship is good. So they may say yes or no. But when you ask them, tell me something about the relationship, that is open-ended question. So they start revealing the things happening between them, and you find that there are so many issues in terms of conflict. So open-ended questions will help you to get more information. Then asking patient gender, it is difficult, but it's very important. Even the partners, how many partners he or she is involved with, right? And avoid medical jargon means you don't give them, just tell them about the diagnosis name. Then that was about the open-ended question, but sometimes the direct questions also very important because uh, many times patients not comfortable telling their problem, so they will take you on tour, very vague complaints, and you will not be in position to get the proper appropriate information. There's wastage of time. Sometimes direct questions also will help you. For example, you should ask about the sexual partners, that do we have sexual partners at the moment? Because the patient may come, a single patient may come to you with the with the complaint of erectile dysfunction. Doctor, I have erectile dysfunction, but then you assume that he is in relationship, he's sexual active, and you'll go on asking other related questions. But when you ask, do you have really partner? He tells that no, I'm single. It means he is having problem, he is having erection problem while masturbating. So asking some direct question is very, very important. So the next slide talks about the differentiation between psychogenic cause and the organic cause. You can differentiate if you ask few questions like, for example, if the onset of problem is recent, that would be psychogenic sexual dysfunction. If it is chronic, that would be organic. And if we ask about the early morning erection question to the patient, he may say yes, then he is getting early morning erection frequently, then whatever problem he is having, it is because of the psychogenic issue. But if he says that, doctor, I'm not seeing erectile dysfunction or morning wood since long years or many months, I'm not getting that, it could be organic. But again, don't consider only early morning erection is patient is not getting, that is organic cause. I have seen that patient with huge stress factor, the sleep deprived, highly anxious patient, even those patients also, they don't get early morning erection, even though the sexual dysfunction etiology is psychogenic. So after taking history and related information, now the clinical examination also very important. So basically, you have to go through general examination. General examination means you have to see whether the patient is obese, check the blood pressure, secondary sexual character, that gives a lot many information. The systemic examination involves multiple examination, like for example, the cardiovascular system, abdominal system, then CNS you have to examine. And sometimes if you suspect any prostate pathology, then the project examination, digital examination also you need to do. Then the last, but very important, that is genital examination is also very important, so that you have to, for example, in men, when you examine genitals, so the glans, head of the penis, the prepuce, the shaft of the penis, to find out some lumps are there, the scrotum to see, to examine any swelling or any accumulation of water or hydrocele. For that, all these genital examinations are really important, so that will help in end up having any diagnosis. After examination, the investigation is important. The general lab investigations, like you have to get patient sonogram done, the urine test, then fasting blood sugar. HbA1c very important, because I have seen in my clinic the patient came with the history of the erectile dysfunction, but the patient didn't have any diabetic symptoms. But when you investigate, the HbA1c is 10.5, so that is very high. So they don't have any diabetic symptoms, but they end up your clinic with only erection problems. So these investigations, general investigation also helps you to diagnose patient properly. The hormonal assay, so obviously different hormonal tests like testosterone very important, thyroid is very important. For example, the hyperthyroidism usually causes the premature ejaculation, and hypothyroidism is associated with the low hypoactive sexual desire disorder. That's why hormonal assay is very, very important. Then semen analysis. If some couple, they're trying to conceive since long time, and even though without using contraception, but they still they're not able to conceive, the woman is not able to conceive, then semen analysis is indicated. Then vascular function assessment test. For example, the Doppler test can be advisable. The Regis scan to differentiate between the psychogenic versus the organic cause, and treatment. These are the same vascular function assessment tests. So management strategy, I will since we have left short. Sorry. So I will talk about the oral management because if you take every sexual dysfunction separately, it is very detailed. So you need to explain how the healthy lifestyle is important because only pharmacotherapy is not important. The healthy lifestyle helps a lot for different sexual dysfunction. So yoga, meditation, or whatever cardio exercise we explain. Then treatment of the lifestyle diseases, for example, diabetes, hypertension, that is one of the root cause. So treat hypertension, treat diabetes, ultimately there could be some improvement in the sexual dysfunctions. The hormonal correction, just now explained about the thyroid, testosterone. If during investigation you found that there is issue with these kind of hormones, you correct them, so probably they will be getting improvement in their sexual problem. The root cause, for example, in psychiatry patients like depression, anxiety disorders, if you treat this is the root cause. If you treat them, obviously the patients start getting desire and desire back and direction back, and even the relationship issues. If you fix it, that will also help, and even the family issues. So root cause, once you find out and you treat that will help to come out of this problem. The iatrogenic sexual dysfunction, I told you, for example, different medications. In psychiatry, we prescribe different psychotropics, antipsychotics, and SSRIs for depression, antipsychotics for psychotic disorder. That is because of the mechanism of action itself induces the sexual dysfunction. But when you change the medication, you need to choose the medication very wisely. You need to choose medication which can treat the depression without creating much problem in the depression. So that will also the iatrogenic sexual dysfunction that will help. Pharmacotherapies, there are so many medications for different sexual dysfunctions. I'm not going into detail. However, in erectile dysfunction, we use the PDE5 inhibitors, different PDE5 inhibitors available in India. And in premature ejaculation, we use different SSRI, and there are so many other even tricyclic antidepressants can be given with different dosages. So my favorite is paroxetine in premature ejaculation. So pharmacotherapy definitely helps a lot. And different devices like in case of vaginismus, the dilator therapy, and in case of even vibrators, that helps. Even delayed ejaculation vibrators also helps. So that comes under devices and the psychological methods. So different the CBT and even the sex therapy. If you find that this couple is suitable for sex therapy and the CBT, so accordingly you can take the sessions on frequent intervals, and that will definitely going to help the patient to come out of this problem. So that was all about the clinical approach towards male and sexual dysfunctions. I hope I have covered at least important points here. So if any questions, I'm open for that. Thank you very much.
Thank you, Dr. Prashant, for very nice presentation on sexual dysfunction, especially importance of history taking, which is integral part of psychiatry. You have highlighted very well and short. Thank you very much.